My talk is entitled Risk Factors and Mechanisms Contributing to the High Burden of Age-Related Comorbidities in Women with HIV. These are my disclosures. So in the time that we have together today, I'm hopefully going to give you a whirlwind tour of the sex-specific burden of non-AIDS comorbidities in persons with HIV. And I'm going to discuss some of the factors and underlying mechanisms that we've studied, including our Emory Score U54 program, that contribute to the comorbidity burden in women with HIV. And this includes chronic antiretroviral therapy, estrogen deficiency, and then the gut barrier disruption. And then at the end, I'm going to highlight a few future directions for our Emory Score program. So there are over 40 million people living with HIV globally, and over half of these people are women and girls. Most of these women live in lower and middle income countries, but there is still a fair amount that live in the US, and in the US they make up about 25% of people living with HIV. We've come a long way over the last 40 years. We don't still have a cure, and no, we don't have a vaccine. But what once was really a death sentence for our patients is now a chronic disease where people living with HIV are able to live much longer and healthier lives thanks to the advent of antiretroviral treatment, which was introduced in 1996 and includes at least 2 classes of medications active against the HIV virus. These medications induce a robust immune reconstitution and viral suppression that really led to a plummeting of deaths and new diagnoses of HIV. What does this mean for us? It means that our patients are living much longer. And in fact, in 2018, half of the patients living with HIV in the US were over the age of 50. So now we have an aging population. So while we've come a long way with bridging the gap of life expectancy for persons living with HIV compared to those without, which are the two line graphs you see at the top, we still have a ways to go with living a life free of comorbidity burden. There is a 16-year comorbidity-free life expectancy gap between persons living with and without HIV. So to try to understand why this comorbidity burden exists, we in our group have leveraged 2 of the longest longitudinal cohorts of persons living with HIV in the United States. The men's cohort, which is the MAX, and the women's cohort, which is the WISE. The MAX was first enrolled in 1984, and in 2024 we were able to celebrate its 40-year anniversary, which is incredible. The WISE started enrolling almost a decade later, just based on the epidemic. And in 2013, 5 southern sites were added, including our site in Atlanta, Georgia, to really reflect where the epicenter of the HIV epidemic is. In 2019, the NIH merged these 2 cohorts, and now we all work together in the MAX-WISE combined cohort study. This cohort study is really amazing because not only is it a lifelong cohort of people living with HIV, but it also includes a very important control group, which is demographically similar persons living without HIV. They're not the general population, but they're a very valuable control group. So my colleague Lauren Collins was one of the first people to try to understand the prevalence of these comorbidities in populations living with HIV. And she started by looking at it in women. And when we talk about non-AIDS comorbidities, we're talking about comorbidities that are not directly related to AIDS-defining illnesses from the HIV infections, significant immune suppression. So we're talking about comorbidities that we see every day in clinical care: diabetes, hypertension, chronic kidney disease, et cetera. And what we saw is that women with HIV experienced a much higher comorbidity burden than women without HIV. and that this was actually most striking in the women that were in the 40 to 49-year-old age groups, as well as older women over age 60. This high comorbidity burden is still associated with traditional risk factors that we deal with every day in our clinical care, including obesity, cigarette smoking, et cetera. When the cohorts merge, this is a really great opportunity to actually look at sex differences. And so then Dr. Collins and our group were able to look at the burden of comorbidities comparing women versus men. And you see persons with HIV are on the left, persons with without HIV on the right. So number one, persons with HIV, again, much higher comorbidity burden than those without. But comorbidity burden was still higher among women versus men, especially at those older age groups. When we pulled the women out again to see how this is affected by menopausal stage, we see that the greatest impact of HIV on comorbidity burden occurs in the perimenopausal and the postmenopausal stages. And again, still much higher than the women living without HIV. We also asked ourselves if it was certain groups of comorbidities that were more frequent in women with HIV versus men. And so this was a nice review that one of our graduate students, Renee Pond, did a few years back. And what we noticed is that women do have higher comorbidity burden overall, but specifically, women with HIV had a higher risk of cardiovascular and cerebrovascular disease, neurocognitive disease, and bone disease compared to men, whereas men with HIV had higher risk of metabolic diseases such as type 2 diabetes, hepatic steatosis, et cetera. And the Emory score, since its inception in 2018, has really focused on these three categories of end organ disease that are found at much higher rates in women with HIV. So what are some of these factors contributing to comorbidities in HIV? Well, it's complicated, as you can imagine, but this is a nice schematic looking at some factors contributing to cardiovascular disease in persons with HIV. So, this is just showing cardiovascular disease, but many of these mechanisms can relate to other comorbidities. So as you can imagine, when somebody is infected with HIV, it results with very rapid immune suppression, depletion of CD4 positive T cells in the gut, and there are many factors that contribute to the development of these comorbidities. Some of the ones that our group has focused on that I'm going to introduce today are antiretroviral therapy. Again, it's lifelong medication that people have to take in the absence of a cure. Disrupted gut epithelial barrier, as I mentioned, when someone is infected with HIV, there is a significant depletion of CD4 positive T lymphocytes, and the greatest population of those lymphocytes lives in the gut. And then this was not included in this schematic, but I added estrogen deficiency because this does play a key role in driving chronic inflammation as well as end organ disease. So I'm going to give you a short overview of some of the work that our group has done in some of these key categories, and starting with antiretroviral therapy. And some of this work really came about from clinical observations. So I'm a clinician. I see women living with HIV in my clinic. And about a decade ago, the integrase inhibitor class of HIV medications started becoming first line. They are recommended by the WHO in all first-line regimens for HIV because they're safe, well-tolerated, and efficacious. They come in one pill once-a-day regimens, and 5 years ago, the long-acting injectable cabotegravir, you may have seen those commercials on television, was really life-changing for many of our patients who could not take pills every single day, but are able to come into clinic every other month for an injection. But when we started switching our patients to these integrase inhibitors, women started complaining about weight gain. Weight gain was not a common side effect that we saw in phase 3 clinical trials. And so many of these women were at first ignored. But if you look at who was enrolled in phase 3 clinical trials, especially in the early days of these integrase inhibitors, most of the time it was about 90% white men. And in my clinic in Atlanta, Georgia, my clinic is predominantly middle-aged Black women. So they were not represented in these phase 3 clinical trials. And so side effects that happened after FDA approval of these drugs were just not noticed. This was a wonderful opportunity for us to be able to leverage these longitudinal cohort studies that I mentioned to really study these medications and the effects on obesity, weight gain, as well as cardiometabolic risk. And with my colleague, Dr. Alvarez, who is in the Division of Endocrinology at Emory and who focuses on obesity pathophysiology, we set out to do just that and to assess sex differences with these medications. And so some of this work that was published last year was really striking. I'll orient you. There's men on the left and women on the right, and we were able with our cohort to look at 3 groups. People who switched to integrase inhibitors in blue, those who stayed in old regimens, their old HIV regimens in red, and those who were at risk but not infected with HIV in orange. And women switching to the integrase inhibitors had a 2-fold greater weight gain than men. And when we looked at where they gained weight, because we had access to waist, circumference data, women gained weight everywhere. So I'm just showing you waist and hip, but as you can see, the patterns are strikingly similar. Men did gain weight in their waist, but all the men did, whereas the women, specifically, it was the women that switched to these medications. We also looked at thigh, and it was the same result. This really concerned us because we know that weight gain and obesity is associated with cardiometabolic risk. And so we next looked at cardiometabolic risk indicators in these patients and saw that I'm showing systolic blood pressure change on the left, and then on the right is a measure of insulin resistance by HOMA-IR. And again, we see these sex differences. We see that women are having a linear increase in their systolic blood pressure over 5 years, whereas the men didn't really have much change. And then on the right, we actually see that men had improvements in their insulin resistance profiles, whereas the women either didn't have much of a change or had worsening insulin resistance over time. When we take these women and we tried to see if the time that they switched their medication was important. And when we did that, we looked at whether they switched, what stage of menopause they were in when they switched to these medications. This work was done with one of my colleagues down the road at UCSF, Rebecca Abelman, and she took that cohort of women, and we had longitudinal measures of anti-Mullerian hormone to determine their exact stage of menopause that they were in when they switched. And really, it had striking results. When women were in pre-menopause, and I'll orient you here, the women in orange who switched to INSTIs and the women in blue stayed on their old regimens, their trajectory of their waist circumference gain was the same if they switched in pre-menopause. But if they switched to those medications in the late perimenopausal phase, you can see this tremendous increase in their waist circumference compared to the other 2 groups of women who didn't change much at all. So this brought us to estrogen deficiency, contributing to HIV comorbidities. What is the role? So what do we know about HIV and menopause? Well, we know even less than we know about menopause in the general population. So many knowledge gaps. Data from cohorts in the UK, Canada, and Brazil suggests that women with HIV may experience menopause 3 to 5 years earlier than women without HIV, but that has not been seen consistently across all studies. And we have very few data from women in lower and middle income countries, and that's where the majority of women with HIV live. Women with HIV experience the same types of menopause symptoms, but greater severity. And this is very challenging clinically to distinguish menopause symptoms from those of HIV and from those of antiretroviral therapy side effects. Women with HIV experience much greater rates of depression and anxiety, and we know that this is complicated by menopause And then finally, we have very little evidence on the safety and efficacy of menopausal hormonal therapy in HIV, although there is a new trial from our AIDS clinical trial group looking at this exact problem and enrolling women as we speak. So that's very exciting. So our Emory score has really focused on trying to understand what the combined effects of HIV and estrogen insufficiency have on end organ health in women aging with HIV. This is the structure of our Emory score team, and I want to highlight that the original PI, Igo Afotokun, my close mentor and colleague, was absolutely instrumental in putting this team of people together. The first Emory score was funded in 2018. And we have 3 cores, and now I now run the Leadership Administrative Core along with my colleague Vas Makopoulos, who is in the Department of Psychiatry and has focused her work on stress and PTSD effects in women. And then we have a Biostatistics Resource Core as well as our Career Enhancement Core. And so the cross-cutting scientific premise of the Emory score is to understand how immune activation and chronic inflammation due to viral persistence can exacerbate relative estrogen insufficiency and lead to end organ damage. And we're very interested in looking at the organs that I mentioned, musculoskeletal health, cognitive health, as well as cardiovascular health. I'll note that we're deploying HIV as a tool for probing the nature of this interaction, but that doesn't mean that other chronic viral infections may not have similar mechanisms. For example, long COVID, could this be the same mechanisms involved? But we are using HIV. So the first cycle of our Emory score cohort was established in 2018. And we spent that majority of that cycle establishing our cohort of women. We have almost 200 women enrolled in our cohort. 2/3 are living with HIV, 1/3 are without HIV. And most of them are nested in that MaxWise combined cohort study that I mentioned. These women were enrolled, they had estrogen status characterization, inflammatory markers measured, as well as measures of skeletal profiling, trauma measures, and cardiovascular profiling with carotid MRIs, coronary CTAs, et cetera. And I'm going to just give a brief little highlight on a couple of projects that we've done just in the interest of time. So Project 1, the Neuro-HPA axis led by Gretchen Nye and Vas Makopoulos. One of the projects that was recently published by our group was looking at childhood trauma and HIV and how that interacts with markers of systemic inflammation as well as estradiol-induced gene expression in women with HIV. So we looked at a cohort of 116 women from our score. These were, on average, middle-aged women at age of 50, predominantly Black, low income, low education, really consistent with what we see in our clinic. And we administered childhood trauma questionnaires and dichotomized childhood trauma as low or severe to moderate. And what we found is that over half of women, whether they were living with HIV or our HIV controls, actually had moderate to severe levels of childhood trauma. And when we looked at childhood maltreatment, so you can see on the left, on the y-axis, we see low childhood trauma and high. We see that irrespective of HIV status, childhood maltreatment was associated with greater LPS concentrations, and LPS is a marker of gut translocation and microbial translocation. We did not see the same association with C-reactive protein. So we then isolated PBMCs from women with known childhood trauma history, both with and without HIV, and the RNA that was isolated from untreated versus estradiol-treated PBMCs. And then we conducted PBMC differential gene expression and analyzed using nanostring technologies. And what we found is that women with HIV showed much more robust estradiol response compared to those without HIV. and this diagram here sees 16 versus 4. We also found that there were distinct expression profiles between childhood trauma groups, so low childhood trauma versus high childhood trauma. So taken together, we see that, number one, there are really high levels of childhood maltreatment in our cohort, and that childhood maltreatment is associated with greater LPS concentrations. HIV and childhood maltreatment together impact how immune cells respond to estradiol treatment. And now with our next iteration of our SCORE grant, we're going to be able to follow these women longitudinally to assess how these factors actually relate to end organ disease over time, as well as the role of the menopause transition. And finally, I'll show some work that we've done on the musculoskeletal project. We wanted to determine how immune reconstitution-related bone loss interacts with postmenopausal bone loss in women with HIV. So a little background. We know that fracture rates are higher in women with HIV. And one might think that that is just because of the HIV infection itself. However, there's a double hit. So my colleague Igo Afodokun, as well as Neil Wiseman, have spent the last 15 years really showing what immune reconstitution bone loss is. So when you initiate antiretroviral therapy, it elicits rapid increase in bone resorption that is positively correlated to CD4 positive T cell response. So women, when they start antiretroviral therapy, and it doesn't matter what class of medications they start, they experience bone loss. And that bone loss isn't reversible. So their skeleton not only takes a hit from HIV, but it actually takes a hit from the HIV treatment itself through the immune reconstitution pathway. So to understand how this antiretroviral induced bone loss interacts with menopausal bone loss, which is a third hit, our team applied a mouse model of immune reconstitution bone loss, either sequentially or simultaneously with a model of postmenopausal osteoporosis through surgical ovariorectomy or OVX. Now, in the clinical setting, this typically, the sequential model is what typically happens. A woman is usually going to be diagnosed with HIV in the premenopausal stage, start HIV medications when she's premenopausal, and then go through menopause. But it is, of course, possible that a woman is at the same time diagnosed with HIV, starts HIV medications, and is going through, is postmenopausal at the same time. So that's why the simultaneous model was also applied. We also assessed the impacts of a checkpoint inhibitor, abatacept, as well as a probiotic on bone loss. And so I'll show these results here for these mouse models. And what we see down here in black is the vehicle. In, I think it's blue, we see the immune reconstitution bone loss without OVX, and then you see the sequential model in red. And there's a significant decline in vertebral trabecular bone mass with IRBL that is exacerbated by sequential ovarectomy. So women getting that first initial hit with antiretroviral therapy, then going through menopause in mice, I shouldn't say women, but mice, really exacerbates the bone loss. When we looked at the simultaneous model, however, we didn't see the same. So going through these things at the same time, immune reconstitution and OVX, actually did not exacerbate bone loss. We think that may be due to the fact that inflammatory pathways are maximized at the time of immune reconstitution, so that even that greater hit of losing your ovaries is not additive. In the sequential model, when we gave both the checkpoint inhibitor and then also the probiotic, both reduced bone resorption and stimulated bone formation. So what we showed is that in a mouse model, sequential immune reconstitution bone loss and postmenopausal bone loss appear to be cumulative. If we can validate this in humans, early screening and prophylaxis could reduce fracture risk in postmenopausal women with HIV. And I think that we showed that probiotic therapy may be a useful alternative to pharmacotherapy, but that much more research is needed to assess the role of gut integrity disruption on bone loss in women with HIV. Which really brings us to the future directions and our scientific premise of our renewed cycle of the Emery score. And that's really to understand how chronic HIV and low estrogen co-act on women undergoing menopause to disrupt gut integrity and promote inflammation. And how does this affect the progression of the end organ diseases that we've seen? So while our first cycle of our score since 2018 has really been predominantly building our cohort of women that I've shown you and cross-sectional analyses, our second cycle is going to be, we're going to have the privilege and the opportunity to follow these women longitudinally. They've now been enrolled in this study for over 5 years, and we're going to be able to get data on longitudinal bone loss, longitudinal cardiovascular disease, as well as additional trauma assessments. And for this go-around, we are really focusing on the gut, measuring markers of gut permeability, stool metagenomic analyses, as well as metabolomics, to really understand how that disruption of the gut barrier is adding to the end organ disease that we see. And I think I'm going to stop here and acknowledge all the people that I have to thank that contributed to this work, including our Emery Score leadership team, our investigators. Big thank you to our funders at NIH. Our score is funded by the National Institutes of Aging, as well as the Office of Research on Women's Health. Some additional funding sources from work that I showed, and I'm happy to take any questions from you all. Thank you.